projection. This is the normal ipsilateral projection. This is an enormous expansion after an injury. So with this representation, incoming sensory information is connected to completely different axons, triggering aberrant motor responses along the whole spinal cord. This explains the chaotic answers to EMG stimulation, even in arm muscles, as well as the astonishing systematic effect of SDR, probably because it selectively interrupts rootlets which trigger the pathologic rewiring along the spinal cord. In this picture, you see a simple S1 stimulation on the left side, and you see an unexpected answer of several muscles on the right side. Interrupting this rootlet also interrupts the pathologic co-activities. In Bonn, we do probably the highest number of SDRs in the Western European countries, with 3 cases a week and a waiting list of 1 year currently. In contrast to the classic indication here on the left, which refers to gross motor function 2 and 3 levels, we extended the indication also to the levels 4 and 5, previously reserved to baclofen pump implantations. SDR, to our opinion, is a valid alternative to baclofen pumps, and also, by the way, a cheaper alternative. Although we already use a single level approach, we still take much care in a kinematic complete reconstruction of the spine during surgery. This is why we do not cut interspinous ligaments. Instead, we split the neighboring spinal processes in an oblique fashion to keep the tendons intact. And after surgery, to have a bony fusion of these split spinal processes with a completely intact dorsal stabilization system, a ligamentous system. We do this because we know from various different surgical indications that multi-level approaches for any surgery, even with laminoplasty, carry a high risk of instability. Now, SDR starts with an intravenous anesthesia as just a regular TIVA with propofol and remifentanil. We install electrodes in all reference muscles of the lower limbs. And also we record the pudendus activity. So we have anal and we have rectal electrodes. This is a kind of primitive navigation. We just take the child through a little MRI we have besides the OR and just mark the conus of the spinal cord and the neighboring spinal process. This will be the cut, the skin cut, to expose the 3 spinal processes, although we do a single level laminectomy here. So you need quite a 16-channel monitoring system to have all the electrodes in place and also to record answers from the opposite side. This is a skin cut. Then this is the exposure of the spinal processes. We just open the interlaminar window with a little punch, and then we take out 1 lamina and we split obliquely the spinous process above and below the level we want to take. And then we end up with one single level opening. This is the microscopic view. And this is also the situation in the OR, where the monitoring guys are right beside the operating table, and in an ideal version also have a microscopic image on the screen to see what we are currently doing. And then we open the dura. This is the conus, and you see the caudal equina on both sides. This is, if it is the level L1, this is the root L1 with sensory motor part. Then we check the lowest vegetative roots S6 up to S2, and we separate the roots L1 or L2 down to S1 on this little pad. And then we go root by root. We can just split rootlets, they are too big, and we do between 3 and 6 rootlets per sensory root. We do the monitoring, we discuss the results, and then we coagulate and cut 60 to 70% of the rootlets. This is very important. We always cut 70%, otherwise the effect for the motor function will be less. Then there is a dura closure, and we put in an epidural catheter for pain management, additional pain management to the intravenous pain management. This is a little piece of bone with one lamina, and we put in a little titanium plate. It can stay inside the cetus. We never take it out again, with 4 little 5mm screws. So this overarching plate just prevents that the spinal process travels somewhere where it should be. So here you can see half spinal process on top and half a spinal process below, and the ligaments which are preserved. And then this plate is with 2 little screws.
¿Qué quieres? ¿Que te lo meta en el culito? Hoy casi te clavo la espada en... Ay.
And then we do a compression suture on the 2 halves of the spinal process, on the split spinal process, just to get a bony fusion, which works always. So we do just a suture, and then the bone is refixed, and this is a stable connection. I show you just some representative results before and after SDR. This is cross-motor function 1 with this tiptoe. I try to...
Please, could everyone mute their microphone?
No, I cannot selectively, obviously, turn down the audio.
Stopp und ohne festhalten, nochmal nach vorn laufen, aber nicht am Geländer festhalten. Okay.
This is an elderly guy who just a few weeks after SDR, still with a couple of problems. But you can already see that he has a much more control.
Und dass du jetzt wieder zurückkommst?
Despite his hip instability.
Warum brauche ich? Besonders für die Kongresse brauche ich sowas.
Oh, it's too loud. And this is a little girl which just ran her first marathon after switching. And finally, an adult lady who for the first time walks down this stair. She never was able before to walk a stair downwards. So what we have to keep in mind is that SDR does not do miracles. Consulting families, we have to keep in mind that the prognostic limits which have been demonstrated clearly in this study by Rosenbaum and his group, they are given. This shows that this is a group of only conservatively treated children, and you see that the children with the highest handicap, level 5 gross motor function, they reach the limit of improvement very early in their age. It's around 3 years. Whereas the children with a lower impairment have more time to improve until the age of 8 or 9. But then they also reach a limit. With SDR, we hope to diminish the degree of impairment and with this, increase the time range for improvement. If we really succeed, still has to be shown. Currently, evidence increases. This British study initiated the national decision to fund single-level SDR in England. And this Canadian study also was the basis for the decision of Ontario to integrate SDR as a basic treatment. The complication rate is very low, astonishingly low. We have a couple of, this is a paper of Park, who did probably most of these surgeries. He's around 5,000 now. When he published this paper, he had 3 wound infections, 7 CSF leakages. It's a very small number of general surgical complications, no specific neurological complications, and also not in our group with currently 480 SDRs. Now, let me finally come back to Cinderella. Everybody knows at least a version of the fairy tale Cinderella, which is, by the way, already known in China around the 9th century, and then going through multiple versions during the Middle Ages in Europe. The common plot is about a young, very modest and beautiful princess growing up in a disgusting, greedy and jealous stepfamily, preferring their own daughters and abusing and torturing the girl. With the help of magic powers, she finally is able to win the attention of the king's son, who falls in love with her, and despite the interventions of the stepfamily, finally marries her. SDR has a similar history. Since the father of this surgery, Ottfried Förster, died, it has become the stepchild in the family of orthopedic interventions in cerebral palsy. Today, despite interventions to prevent its growing popularity, it's about to achieve the place it deserves as a first-line prophylactic surgery to prevent and diminish later orthopedic interventions. This is Robert Abbey, who did the first SDR in the United States. And then this is his surgical sketch, which was published in the New Yorker. And this is the part of history which is not known. At this time, SDR became very quickly a very fancy surgery all around Europe. There was the First World War starting, and in all kinds of untreatable pain, people tried to do SDRs. And they collected, as we can expect, various, let me put it politely, various results. And at the end, the method was disappointing because it was used in a very diffuse number of indications. And at the same time, Förster, here with his pupil Wilder Penfield in Germany, and here touring it through the United States with Cushing, Förster focused the surgery on spasticity, and his results in these 80 cases were absolutely correct. He had 51 cases of spinal spastic paraplegia, Little's disease, 45 successful, 1 not benefited, 5 deaths, which is historically, beginning of the 20th century, not a bad result. And these are the very clear documentations of his results. But at this time, the method had already lost its reputation, and it was just forgotten for 40 years. So, I don't want to go through the whole history, but today, SDR in this single level technique, and this is why I show you this picture of the St. Louis Children's Hospital, where I had the chance to be trained by T.S. Park, who developed this approach, is about to become a promising first-line treatment in young CP patients. Thank you very much.
Thank you, Professor. I'm going to start the video. Thank you very much. It was an impressive amount of patients that you operated on, a very large experience, and I'm not so familiar with the procedure. There was one question on the chat, but about a patient, but I don't know exactly which patient they mean. And there was a question about whether you perform only SDR or also orthopedic surgery. About
yes.
the first and the second patients you showed in the video post-operatively, I can read.
If I got the question right, it's about the combination of orthopedic surgery and SDR.
Yeah, exactly.
Yes. Our setting, and this is very important, is always to have all the expertises in one room. So I never see patients for SDR alone. I have an orthopedic surgeon in the room, I have a neuropediatrician in the room, and I have a physiotherapist in the room. And the decision which package of therapy we do is always taken together. If people go to different specialties, you always sell what you know best. So if they come to me, the first thing I think of is SDR, but maybe it's not right. So our indication scheme, this is a little more complex, is that in simple and a few structural changes in a child which need orthopedic correction, we would do SDR first and then add orthopedic surgery. If a child has complex, multiple structural changes and would probably not profit anymore from the freedom we give the child by reducing the spasticity in SDR, we would doubt the indication and we would probably go for first-line treatment, orthopedic corrections. But orthopedic corrections always deal with damage which has already occurred, and SDR is a prophylactic surgery. That's why SDR, if you have the choice, should be done early in life. Like the ideal group would be between 3 and 5 years.
Okay, that was my question as well. What is the minimum age on which you perform this procedure?
Yes, I think 3 would be fine because children should already have an idea of walking if they are functional, and because this is much easier for the rehabilitation. When you do SDR before they start walking, it's difficult to rehabilitate the child. So 3 would be fine. There are still not so many structural changes at this age, and then rehabilitation is easier.
Okay. There was one more question. It's already answered by Dr. Knight. So how you select the root level? Is it always the same levels that you cut? The
same levels? Yes, we do a standard procedure. We cut from L1 down to S2.
Yeah.
But the access changes because the conus medullaris may be at T12 or at L1 or at L2. So this is only a question of approach. We always have this little window of 2.5 centimeters where we can overlook L1 down to S1 as they directly at the conus.
Okay, and then there was one more question. What about the sensory deficits? Probably there are some deficits postoperatively and
Fortunately and astonishingly, I have to say that there is not a single child with a persistent neurological complication after surgery. This sounds really a little bit, suspicious, but it's like that. The thing which happens regularly is that children have a temporarily hyperpathy. So for the first 5-6 days, it's very uncomfortable for them if you touch the legs. This is one small thing. The second thing is that the interruption of 60 or 70% of sensory routes initiates a temporary loss of control. So after surgery, the first 2 days, if you try to put a child on its feet, it will just crack down because it doesn't know how to control them. This is not a question of muscular strength, it's just a control loss. And the goal of rehabilitation is to regain the control. The smaller children walk out of the hospital after 1 week. The elderly children need maybe up to 2-3 months to come back to the functional condition they have been before surgery, but then they improve.
Okay, thank you. And I think we should proceed to the next talk, and all the other questions can be answered by that.
Thank you very much for having me.
Thank you very much for your interesting talk.
Thank you.
Thank you, Manuel. I will now take the opportunity to introduce our next speaker, Professor Deepak Gupta. He is the Professor of Neurosurgery at the All India Institute of Medical Sciences. He's also the Director of the Pediatric Neurosurgery Fellowship Program. Is the lead faculty for trauma care at the All India Institute of Medical Sciences and the JPN Apex Trauma Center. Professor Gupta is also the Secretary of the Indian Society for Pediatric Neurosurgery, and he's the member for Neurotrauma Committee at the WFNS, representing the Indian subcontinent. He's faculty of the AO Spine, AO Neurotrauma, ATLS. He's also past secretary of the Delhi Neurological Association. He's been pretty much a leader in a number of societies. And most of you will know him for leading the craniopagus team of more than 100 specialists that delivered India's first successful craniopagus separation in 2017. He has published enormously, something like 260 publications to his credit. Very passionate, very well, internationally well known in the field of neurotrauma, and I'm really delighted to invite him to deliver his talk on controversies in the management of head injury. Deepak, go ahead, please.
Thank you, Girish, for your kind words. First of all, I would like to express my gratitude to Naren for giving me this opportunity. I last attended this course of Naren in Malaga, if I remember correctly. And it's been almost like more than 4 years that I'm a part of it. Is my screen visible? My PowerPoint first slide?
Yeah, it's visible. Yeah.
Visible? Yeah. Okay. All right. So as compared to the previous speaker who talked mainly on the surgical techniques, my talk may be a little bit boring, I would say, because I will be talking primarily on data and our experience in the management of pediatric head injuries. I don't have any conflict of interest. This is my place of work, that is JPN Apex Trauma Center. It actually is the first level 1 Apex Trauma Center of our country, India. And this is where my main hospital is like. It is All India Institute of Medical Sciences. It's in New Delhi, capital of India. You know, like the problem is most of the clinicians or the end care providers who are giving care to these children with traumatic brain injury, they consider them as a small adult. While the actual truth is that a child is not a small adult. You know, if you look at the 5th to 7th century old paintings, the children, they were actually portrayed as miniaturized adults. Okay. But if you look at the 15th century painting of Madonna and a child, in which the child is actually portrayed like a child with a large head, large belly, and small limbs. And I think the same mistake the clinicians also were doing 5 to 6 decades back. wherein they were using the data of the adults and they were extrapolating it to the children. However, it is not true. These children, when they sustain a traumatic brain injury, they do have, many of them actually survive. They do have longer life expectancy. However, they do have longer time with the disabilities also. The children are very different as compared to the adults because it is considered that they have got higher mortality as compared to the older children. The primary reason could be because the neurological assessment is very difficult in these young children. In children less than 1 month of age, you require specific tools. And there is often underestimation of the injuries in these young children. And most of the times, the battered baby syndrome, which I will not be covering because I believe another speaker is covering, it often remains undiagnosed. And often I feel that there is always a reluctance to start invasive procedures in these young children. At the same time, we must also understand that the developing brain is probably more vulnerable to apoptotic neuronal death. In fact, the highest mortality is noted in the children less than 0 to 4 years of age. This is what we have historically. However, the data which we have got recently from the recently concluded prospective observational study called ADAPT study, wherein 1,000 children were prospectively studied over more than 70 centers. We did not find this finding. I'll come to that later. For the benefit of the younger audience, those who are attending, we must understand that the children, the brain of a child is very different than the brain of an adult. It has got more of a water content, it is less myelinated, and hence it is very prone to acceleration and deceleration injuries. If you talk about the types of injury, they are again very different in the children as compared to the adults. They have got less traumatic lesions, they have got less hemorrhagic contusions as compared to the adults, and they have got more incidence of the diffuse brain swelling and axonal injuries. In fact, the white matter shear injuries, I would say, is 2 times more. The cerebral edema is more because of the cerebral hyperemia in the young children as compared to the adult counterparts. You know, when we are providing care to these children in the emergency room itself, we need to be extra careful because the young children, they may not have signs of hypotension and they may have sustained blood loss of more than 30%. All they may have is just subtle tachycardia because this is how their physiology looks like. They have got a very high minute ventilation of the oxygen demands as compared to the adults. They're in the anabolic phase, I would say. So their caloric and the water needs are very high as compared to the adults. They've got very large head, so the incidence of injury to the head is very high as compared to the other torso injuries. If you look at the ratio of the face as compared to the head, it is almost 8 times in the children as compared to the adults, when it is 2.5 times. Excuse me. So the incidence of the sustaining injury to the head is very high in the young children as compared to the adults. The large head again accounts for the difficulty in the maintaining the airway. They've got large tongue which may often fall back. And because of the large head size, when you position these children without any support under their torso, you know, they may have some obstruction of the upper airways. So you may have to really put some pad or torso in the emergency room itself to open up the airways in these young children. You know, these are the things which should be there in all emergencies. All emergencies should have breast loss tape, wherein you know how much, what fluid, what drug to give to a child based on the children, their height, which you have in the emergency room setup. So all these things are very important parameters. The care of the child with head injury begins in the emergency area, I would say. This battered baby syndrome, I'm told by Naren that another speaker will be covering, so I'll skip it. However, such injuries are not very uncommon even in India and other parts of the world, and one needs to be extra careful and vigilant to keep a watch and to manage such injuries. One needs to know about the pediatric Glasgow Coma scale, which is slightly different as compared to the adult counterparts, because in the pre-verbal children, you have to look at the different components, especially in the children who are very young. for looking at the verbal parameters. You often need to take a detailed history from the parents, and you often need to look at the temporal sequence of the changes taking place in the child's sensorium and other parameters before reaching to some diagnosis about the severity of the head injury. Now, I've been given the topic of controversy in pediatric TBI. So I would say that the first controversy is whether to do CT or not to do CT when a child with a minor head injury comes to you in the emergency. There is no controversy in doing a CT scan in moderate and severely head injured when the GCS is 12 or below. Children with GCS of 14 and 15, in fact, when you do a CT scan, the chances of picking up a CT of picking up an abnormal finding is less than 1%, I would say. In fact, in a Pekran study, it was shown that in children less than 2 years of age, the chances of picking up an abnormal lesion in a very low risk group on a CT scan was less than 0.2%. Now, the problem that comes is, we are always very careful not to do a CT scan because of the inherent risk of development of malignancy in the long term in the literature available. However, the CT remains as a gold standard, I would say, and it is very reassuring to the parents. At times they may demand CT scan in the very young children with minor trauma also, and children often have got atypical or vague symptoms. So there comes the relevance of surgical decision by the end care provider whether to do or not to do CT scan, especially in the minor traumatic brain injured. So these are the two major, I would say, the Canadian and the English study available, wherein they included more than 4,000 and 20,000 children in each of them, wherein they identified if the children, the GCS of 13 to 15, that is a minor head injury group patients, when they have a high risk group like GCS less than 15 at 2 hours after injury, suspected open or depressed skull fracture, history of worsening headache, irritability on examination, and if there was any sign of basal skull fracture, large bogey hematoma of the scalp, or if there was a dangerous mechanism of the injury, in those cases, the CT scan was indicated. However, it was noted that after this study, especially the Chalice study, the incidence of CT scan increased almost from 19 to 46% in this group of patients. There was this interesting study, the PECAN study, the Pediatric Emergency Care Applied Research Network Group study. This study was actually the only study which was derived and validated prediction. And this study was done to indicate the rule to decide when to forego head CT or when not to do CT scan in children when the GCS is 14 and 15. In fact, this is what I was talking about in the beginning. If a child was less than 2 years of age, normal mental status, no scalp hematoma except frontal, LOC less than 5 seconds, non-severe mechanism, no palpable skull fracture, normal behavior, there is no benefit of doing a CT scan in such group of children. The second controversy is regarding the role of MRI in severe traumatic brain injury. Well, the CT remains the gold standard as I've just told. However, there is no current consensus on optimal timing and sequencing. What are the sequences you should do of MRI in severe pediatric TBI? Well, we do understand that MRI is superior in terms of picking up diffuse axonal injury, early ischemia, brainstem injury, cytotoxic edema, microhemorrhages, contusions, and of course for outcome prediction. In fact, the most valid indication as of today, wherein clinicians like to do MRI in young children with severe TBI is for outcome prediction. In fact, recently I'm a part of ADAPT study. I'm the principal investigator from India, and wherein 27 out of 48 centers that participated in this MRI study, it was noted that almost 40% of the sites, they did some kind of a MRI in more than 95% of the cases. And interestingly, it was noted that the US site, the American sites, they did MRI in more number of patients as compared to the rest of the international sites. 60% of the sites, they did MRI within 1 week post-trauma, while the remaining sites, they did MRI within 30 days of the trauma. One can do various sequences. However, it is always better to be quick. So standard T1, T2 and flare sequences, they give you enough information which you require in your group of patients. Now, we do have Pediatric Brain Trauma Foundation guidelines of 2012 as compared to the adult guidelines, which have been regularly updated as back as 2016. And these are dynamic guidelines. We don't have any updates of the Pediatric TBI guidelines. And all these guidelines, which are in the red you see out here, they all are based on the class 3 evidence. You talk about maintenance of cerebral perfusion pressure more than 40. You talk about maintenance of avoiding PaCO2 less than 30. And of course, about the various, the barbiturate coma, DC and other things. All these are based on class 3 evidences in the pediatric population. So the controversy comes is, do pediatric guidelines impact outcome? There was this Pegasus study, the Pediatric Guidelines, Adherence and Outcome, which was carried out by the Seattle group, wherein Monica Vavilala was the principal investigator. And she noted that with 1% increase in the clinical practice indicators, the outcome improved by almost 6%. And this was a huge, huge difference. They identified protective PQ indicators, that is a CPP of more than 40. Enteral nutrition when started within 72 hours, avoidance of hyperventilation or PaCO2 less than 60 in absence of herniation, and maintaining a normal temperature, that is temperature less than 38.5 degrees Celsius. So this Pegasus pathway showed improved guideline adherence from 64% to 80% in a single center. In fact, similar to this pediatric counterpart, I was the investigator from India, wherein we did this beautiful study called Chirag study in the adult counterparts. And we also showed that when there was an adherence to the guidelines, ICU adherence and after shifting to the ward adherence, when we adhere to the guidelines, the outcome improved by more than 2 times. So this Pegasus study, the Chirag study, and all the previous studies available, they do tell us that there is a distinct and a definite advantage of following guidelines which are available to us. Let them be class 2 or class 3 evidences, but yes, there is always an advantage of following the guidelines. In fact, if we look at this figure of All India Institute of Medical Sciences in 2013, we had almost 40% mortality in the severe TBI. But then 2014 onwards, I was a part of the ADAPT study, and we had just concluded the Chirag study. And look at the dip in the mortality, and currently our mortality is less than 10% in severe TBI in children. And that's a huge, huge difference. And that's only because we started adhering to the guidelines very strictly in our center. So do protocols or guidelines make any difference? Well, my answer would be yes. Next comes the controversy about ICP monitoring. You know, what should be the ideal ICP values? In adults, if you look at the statistics and the figures, when there is a shift of 10 to 15 millimeter is considered as baseline, and 20, more than 20 is a magical figure, which is often considered to be abnormal. And the BT of 2016, I think, talked about a magical figure of 22, which was derived only from one study from UK, I suppose. So basically in adults, you are taking a 50 to 100% rise as an abnormal, from 10 to 20 as abnormal. However, in the children, when the normal ICP is around 5 to 7, why the hell are we taking up to 20 as abnormal? That means we are accepting more than 400% rise as abnormal in the children. And of course, let me tell you, the open anterior fontanelle is not a guarantee that child will not deteriorate. There are hardly any studies, the class 1 randomized studies available in the children on decompressive connectomy. I think there's only one study of 27 cases as compared to many randomized studies called TECRA, Rescue ICP, Rescue ASDH, which is available in the adults. In fact, the usefulness of decompressive connectomy in children is likely to be answered in the part 2 or the ADAPT 2 study, which is going to begin in a year or so from now. This was a very interesting case I want to share with you. A 7-year-old child who presented to us with history of fall from height. He had labored respiration and his GCS was 8. So we provided a standard ICU care. And as a part of the protocol, less than 8 or below, we do insert ICP, intraparenchymal ICP catheter. And if you look at the CT scan, by and large, it looks grossly normal. The fourth ventricle is seen, the cisterns are pretty seen well, the gray-white junctions are seen well, the ventricles are normal. There is no Sulci-Garay effacement. So to majority of the end users, the CT scan looked normal. In a child, when the ICP was inserted, the ICP initially was 15, opening ICP. However, 2 hours after admission, the ICP increased to 40 millimeter of mercury. And so at that time, we were more and more kind of pro toward doing decompressive connectomy. So calling it a case of refractory raised ICP, we did a decompressive connectomy, and the child improved. And the child at 5-year follow-up is studying in the school, and he was discharged, I think, 5 days after the surgery. So we have this mobile CT scanner in ICU. We do bedside mobile CT for all the cases who are there in our neuro-intensive ICU. And all the care is provided in the semi-closed ICU pattern which we have at our center. Now I'll share something very interesting. So the first case I've just shown you the case A, wherein the child was managed with the decompressive connectomy in 2009. In fact, almost a similar looking scan you see of another child where the scan looks grossly normal. It was a case of another severe TBI case. When you look at the ICP values, the ICP trend, you will see all these spikes of 35, 40 values. The first reaction of an intensivist or a neurosurgical resident in the ICU looking at this wave will say that, oh, fine, go ahead and do a decompressive connectomy. However, over the last 7 years, we did kind of started seeing more and more cases and started studying these cases in detail. Then when we look at this ICP trends, these waves are the fluctuating waves. They're actually more like a plateau waves, which is actually more of a vascular phenomena, of a vascular dilatation and constriction. And such cases, they score extremely well for medical management. So this case was managed by the medical management alone. So you can see the similar cases, Can it be muted, please? Thank you. So you can see 7 years down the line, the similar case we managed with the medical management. This was another child, interesting child I want to share with you. This is a large extradural hematoma in a child with the GCS was 6. The normal thinking would be, you just take out the hematoma, the EDH, and don't do anything. However, because it was a part of our policy, we did take out the extradural hematoma, and then we put in the ICP also in this child. So when we did the ICP, the 40 cc of EDH was evacuated and adequate hemostasis was achieved. The opening ICP was 23 in this child. However, on the post-op day 1, the child ICP was 16 to 22. Since we had taken dual stitches and everything, hemostasis was good. So we started 3% hypertonic saline as a part of our policy. On the second post-op day in this child, the ICP started rising to 25. And when we did the CT scan in the child, because of the rising of the ICP, we found the arterial infarct, probably from a carotid dissection from a skull-base fracture which was there in this child. So we went ahead and inserted the EVD, and there was a temporary reduction in the ICP noted. You can see this arterial territory infarct noted in this child. In top, there was no problem when the EDH was evacuated by a resident. However, this is what we saw on the post-operative CT scan. So we do have these pediatric guidelines of 2012, wherein it is documented that if you have a child with early failed medical and surgical therapy, there is a role of decompressive connectomy with duroplasty. So we went ahead and we did the decompressive connectomy in this child. The ICP was reduced to some extent, but then there was a secondary rise in the ICP, and this was the time we subjected this child to barbiturate coma, which was given for 3 days, and subsequently the child improved and he became M spontaneous 10 days after the primary trauma. The child was discharged and he had his cranioplasty, and at 4-year post-op follow-up, the child is back to normal life and is studying in a school. So this case shows the importance of doing repeated CT scans, based on the ICP values, the importance of doing a ICP monitoring in severely traumatic brain injury patients, and of course, you must use all your resources, let it be surgery, medical management, and barbiturate coma in saving such cases. Recently, we were a part of this ADAPT study, which included 1,000 children with severe traumatic brain injury and undergoing ICP monitoring. And we looked for the various aims, that was the efficacy or the usefulness of CSF diversion procedures, the external ventricular drainage, the hyperosmolar therapies, mannitol or hypertonic saline, and the benefit or the loss from the hyperventilation and hypoxia in this group of patients. And we also look for the role of the nutritional strategies and early feed starting or the glucose management in this group of children. The primary outcome being extended Glasgow Coma Scale. Well, I cannot disclose the results. The recruitment has been finished and the data analysis is going on. Only one thing I can share with you is that if you talk about the CSF diversion, as contrast, in contrary to what we expect, that external ventricular drainage will have a better outcome. From a pooled analysis of almost 300 plus children in this study, the CSF diversion group did not fare better as compared to the counterparts. These are the data of our All India Institute of Medical Sciences. We contributed 76 cases to the study, and 55% of the cases were managed by the conservative management in our study. We had we used to prefer more of mannitol earlier, but now in the last 2 years of our practice, we have shifted almost to 3% hypertonic saline in our group of children. So the only thing I can share with you from this cohort of 1,000 children of the ADAPT, which is unpublished, the female gender had a decreased mortality. Abusive head trauma was quite common, noted in 23% of the cases of this ADAPT study, but it was not associated with increased mortality. Age less than 4 years was associated with increased seizures, hypothermia during resuscitation, however, decreased mortality. You know, this is a shocker, I would say, but because normally we believe that children less than 4 years of age will have a worse outcome. However, the results were not so in this 1,000 children with severe TBI in the ADAPT study. The single parameter which emerged as a very important parameter was GCS at ICP insertion was a strong association with the mortality. In fact, if you see it from a different perspective, I would say the decelebrating children, like M2 children, 21% mortality, which I would say is not bad. And nowadays, the outcome has improved so much with advances in the medical management of these children and the strict guidelines which we followed. Even in children, when the GCS was 6 to 8, less than only 3% of the children died, which I would say is a remarkable improvement in the mortality statistics in this group of severely traumatic brain injured children all over the world. So I would touch upon hypothermia, barbiturates, and decompressive connectomy a little bit due to the paucity of time. Well, this case was a 14-year-old child who was brought to us with history of repeated head banging to the wall by the father, and his GCS was 6, and he had severe pallor and severe facial edema. This is how the CT scan of the child, which was pretty bad, I would say it looked like. However, we managed this child with aggressive medical management, and again, barbiturate coma was given to this child. And this is how the child looked like, I think 7 days later. And he had to be tracheotomized. But he's a happy child, and the child is now waiting for decannulation. This was another girl, 7-year-old girl, who presented to us with history from. We have this fall from height very, very commonly seen in our country. In fact, we see less of road traffic accident in children and more of fall from height in our group of patients. And this girl had a GCS of 7 and she was an AIS of 4. There was a
again, yeah, my disclaimer is that there is a lot of controversy on this topic, but hopefully, hopefully, you know, that we can discuss it today and have a consensus opinion of how we should do it.
Continue. So this 7-year-old girl, she presented to us with a posterior fossa bleed.
Classic headache
stop now.
in the
next
posterior occipital region. Otherwise, there are no brain, as well as the cervical spine. You can see the Chiari malformation.
All right, I'll continue. So,
Dr. Gupta, could you please wind up the talk in the next two to 3 minutes, because we have got another session. That's the last session starting at 4:30. And
perfect. Just give me 2 minutes. 2 minutes, I'll come to the last slide. I'm sorry, I overshot it.
Awesome.
Anyhow, so this girl again was managed with a combination of posterior fossa decompression. So we used barbiturated coma in many group of our patients. And our center used to do a lot of decompressive once upon a time. In fact, we have a large study of 71 cases of decompressive in young children. However, lately we have shifted more to the medical management. This was a young child recently operated who had an intro cardiac arrest and was actually revived on the table. You can see as anesthetist doing the resuscitation, and I think this child operated in January. This child actually improved subsequently, and we did a cranioplasty, and this is a happy child and discharged home satisfactorily. So there's a controversy regarding the ideal material for cranioplasty, which I will not go to in the paucity of time. And our recommendations are primarily based on the experience from the ADAPT study. And we are doing more of ICP-based management in the severe TBI group of patients. And I personally, the only message which I want to give to the younger audience is that they should always bring a clinician between the patient and the monitor. Do use your clinical acumen before offering treatment to this group of patients, because a fool with a tool remains a fool. So to summarize, eight specific guidelines or the individual management is required for the pediatric age group patients. One should have a high index of suspicion, but one should have a higher threshold for investigation in this group of patients. As I just said, continuous CSF drainage does not offer advantage. One should consider barbiturated or hypothermia and refractory raised ICP. And DC with the duroplasty should be reserved only for the selected group of patients. And one should adhere to the guidelines to improve the outcome. And this is what we have learned from the previous study, from the PEGARAS and also from the ADAPT study. Thank you so much.
Just get Girish back on the.
You will see some constricting band of dura that is present at the foramen magnum, and there may be on some small percentage of children.
Who can everyone please mute the microphone, and there's a interference coming through, guys.
Yeah, there's a lot of disturbance. I can't make out what the other person is asking, the other side.
That's okay. Sorry about that, but it's difficult to find who is causing the trouble. Girish, I'll just put Girish back on.
Here, the tonsils on the right have descended much more than the one on the.
Okay, I will just take this from them now. Dr. Gupta, there are a lot of questions for you on the chat box. Please accept my apology because of the next session starting quite soon. I want to just give everyone time to stretch, if that's okay with you. But please, if you could please go through. But thank you very much for the fantastic lecture. With your contribution to pediatric head injury, you have been pioneering this field. Very grateful and to have you here. Thank you very much, sir. Okay, so just as a housekeeping announcement, so we will restart again in 15 minutes. We got a fantastic session. And once again, please, everyone, keep your microphones apart from the speaker on mute. And at the end of the session, I will give you the link to give the feedback, because we need the feedback for the Royal College of Pediatrics and Child Health to give us the CME points to give it to you. And we have got one of a fantastic session in the evening. So please look forward to seeing you in 15 minutes. Thank you.
It's the tonsil and their descent, and then again this kinking of the midline.
Hello, Naren here.
Naren?
Yeah,
I'm not sure what happened. What happened?
it was coming from your computer, Girish.
Was it coming from my computer?
Mm.
Oh, I'm so sorry, buddy. I
Don't
kept looking to see where it's coming from.
worry, don't worry. This internet, these systems are always.
But could you hear it?
Yeah, every time I on yours, it came.
Oh, Jesus Christ. This is why I was sending you those messages,
Yeah.
trying to find out. Who was the speaker?
Mm-hmm.
Who was the
That,
speaker?
that was George Jallo's talk.
Was George Jallo's talk
Yeah,
coming from my computer?
yeah.
How did that happen?
I don't know.
Oh, shit.
Not
So
to-
this is why I thought suddenly there were two presentations going on.
yeah.
So anyway, that's the end of the session. Is that right?
Yes, yes. Thank you very much.
I'm so sorry about
No,
this.
no problem at all. No problem.
What probably happened is I had the program,
Yeah.
your website open,
Yeah.
and sometimes these things just pick up automatically, because it's live.
Yeah.
You just start running.
Yeah.
You
And
think-
I had the same problem when I activate the YouTube, then that starts to feed into this one and causes all sorts of problems. So sometimes the internet browser in the back sometimes just gets triggered. So,
Okay, but Deepak's presentation was all right. He wasn't aware of it, was he?
no, not at the very end only. Then I took over the control. So
Girish and Naren, your conversation is audible to everybody.
that's okay. We just wanted everyone to know what happened. That's all. No problem.
Thank you. Sorry to interrupt.
That's okay.
Thanks, Pragnesh. I appreciate that. Okay, we'll have to take this offline, then.
That's okay. No problem. Hello, Mr. Walsh. I'll just make Mr. Walsh.
Can you hear me, Naren?
Yes, Mr. Walsh.
That's good. And I've got a reasonable picture.
Oh, fantastic.
Okay, you all right? Is that okay?
Yes, very good, thanks. Very good. I'll just get Professor Karangal. Professor Karangal. So, Mr. Walsh, the way we have been going is that the chairs have been alternating in moderating the sessions.
Okay.
And we have been very good at keeping to time.
Okay.
And mainly that we kept to time so that the last session doesn't get, the other sessions don't run over to the last session. So we don't have that much pressure on the last session. And
Yeah.
in terms of the, we had one or two niggles in the last session with some interference, but I think that should be okay this session. But
okay.
Otherwise things have been absolutely fine. Thanks.
So the next session goes as in the program.
Yes.
So it's Professor Salmo first.
Professor Salmo first. Professor. I'll just get the program.
Shlomi Constantini next.
Yeah.
And then Sama Elbaba. Okay. Frederick.
And then Dr. Boop, then Dr. Lawton, and then the recording of Professor Miss Dr. Goodridge's talk on craniopagus students.
Okay.
I'll just come back in 2 minutes. Thank you.
speaking? Let's start in 5 minutes. Girish was causing a lot of interference in the last week. Something's happening in causing a lot of interference in the last session. Lorraine said that. Obviously, see that there's a lot of noise around the
It's really good now and technically
no, it's okay, fine. We'll come and see whether how set.
and tomorrow also meeting.
Yeah.
Good. Hello, Professor Salamua.
Yes.
Hello, sir. How are you? Thank you.
Fine.
Honored to have you. I'll just make you a co-host, so you should be able to.
I close the door like this. It's not easy.
Hello, Professor Stanimo. It's Richard Walsh here.
Are we ready?
Yep.